Afternoon and welcome to Facebook and our latest edition of Care Fertility. We are hoping to answer as many questions that you've sent in as possible. There are quite a few, so we'll try and be as quick and cover as many as we can. You will have chance to review this video because it'll be available on playback. And also, if you keep sending your questions in, we hope to answer as many as we possibly can afterwards. I'm Professor Charles Kingsland. I'm the Clinical Director at Care Fertility. And
I'm Alison Campbell. I'm the Group Director of Embryology.
And before we start, I'd just like to make an announcement because my colleague, Alison Campbell, was awarded her doctorate last week. So congratulations.
Thank you.
And so she's now Dr. Alison Campbell.
Wow.
So not only is she beautiful, she's very clever. She's my friend. And I have a card.
Oh, thank you.
And also,
Oh, bless.
this is from the Kingsland Jam Lab. It's my
Wow.
very own
Oh.
blackcurrant jam.
That's
So enjoy
nice.
it.
Thank you.
Well done.
Oh.
Congratulations.
Oh, how lovely.
So, it's a bit sticky, sorry about that. So we'll start with the first question. Is there a big waiting time for appointments? Well, the answer to that is no, there isn't. There is a very short time for appointments. If you're self-funding in Care Fertility, I would imagine that the general time is under 2 weeks. If you're an NHS patient, because of the COVID restrictions, it depends where your CCG have put the funding and which clinic you're going to. So if the funding is with Care Fertility, we have relatively little in the way of waiting lists. Some clinics elsewhere in the country might be a little longer, but generally speaking, the waiting lists are not too long at all.
No, I know, and we didn't know what to expect, did we, after the close down? But we spent much of that time just getting prepared, reorganising the premises, just refreshing everybody's training, communicating with patients. So once we got the green light to resume practice, we were ready, and so we've been working hard, and it's running very smoothly.
Yeah, there are some clinics, for example, my clinic in Liverpool, you can be seen face to face or by telephone consult. In Manchester, I think the situation is the same. You can inquire to your local Care Fertility clinic as to how you would like to be seen, whether you want to be seen actually in the clinic or by a remote video, Zoom, Starleaf, whichever app you have, or by telephone. So if you contact your local clinic or you contact our central inquiries through GEM, they will tell you the waiting time and how you'd like to be seen. Okay.
So the next question from Wild Ride Fertility. So will my partner have a semen analysis at our assessment appointment, and will I have a scan? And will we get these results on the same day? So yeah, we're working really flexibly at the moment, trying to coordinate, as we've said. Some appointments are remote and virtual, some of them are on site. But where possible, yes, we are aiming to get the semen analysis and the scan done so that we can have a really comprehensive first consultation with all of that information.
If you've had semen analyses or scans or blood tests elsewhere, please bring them along because they'll count and they'll speed up provided they've been done in a reputable laboratory, we can use that information together with your consultation, so that might save a little bit of time and a little bit of money.
That's a good one for Charles here. Can you tell us how a first consultation occurs? What happens? What do you say?
Well, most people who have a fertility problem will have done some research and they'll have chosen our clinic. There's a lot of other clinics that you can choose to go to, but you'll come to see us, whether it's been recommended by a friend or member of the family, or indeed through social media. What normally happens is that you will have a lot of information at your disposal already that you've learned from Dr. Google or from other family and friends, or maybe from another clinic. But what we want to do at your first consultation is to spend all the time that you need to understand the basics of fertility, because a lot of people will be given so much information that they don't know how to filter it. What's important, but most importantly, what is essential that you need to know as a couple. Things like your age, your past history, whether you've been pregnant before, your weight, your alcohol intake, your smoking habits. All these sort of things need to be taken into account and sifted through. And then, with the aid of some simple tests, you don't need lots of complicated tests, unlike what some outlets will tell you. With the help of some simple tests, we can then make a diagnosis and point you in the direction that will give you the best chance of success, because that's what we want, the best chance of success as quickly as possible. One of the other factors which is also essential is that you will need to know exactly how much it costs for you. All too many times patients will come to the clinic with no idea how much it's going to cost you as a couple. So one of the factors that we consider to be essential is that you know exactly what you're paying for at the time you start your treatment. So there are no hidden extras, there are no nasty surprises along the way. And in fact, it might even turn out to be less expensive than you initially thought. Many patients have come to see us and they have an idea that it's far more expensive than it actually is. So that's important. So you'd leave with a full diagnosis and then how much it's going to cost if you need to embark on any treatment. Okay?
Mm-hmm. I was just going to mention here, because I've seen a few questions coming in. We've got questions that have been sent in before, so we're going to tackle most of them first, but if we can weave any in that are coming in now, we will, and then we'll get to those afterwards, and then if we can't get to them at all during this session, then we'll respond later on privately to you. But talking about the consultation and the different factors that come into play, I think it's important to say that we've got a really big network of clinics and specialists, so over 100 embryologists. I'm estimating 40 consultants. So if there are complex medical conditions, and there's one here come up in a question, then the likelihood is that if one of our medics hasn't faced that before or doesn't have direct experience, then we will be able to get that expertise together. We'd certainly learn from each other. Another question was related to the body mass index. So there was a question here about would we recommend a special diet? And this lady's body mass index, BMI 25, and the husband's 32.
You sure that's their body mass index and not their ages?
Oh.
It might be there. It might be. You have to. It's important that you prepare for your fertility treatment. There is no doubt that weight has a very significant effect on fertility, and generally the more overweight you are, the less fertile you are. We all know that there are many. We have friends who are grossly overweight and have a good fertility, but that's probably because their fertility was excellent anyway. There's no doubt, though, that if you are overweight, by reducing your weight down to an ideal, that improves your chance of getting pregnant. And normally we would like you to have a body mass index of between 20 and 25. And your body mass index is your weight in kilograms divided by your height in meters squared. So it should be between 20 and 25. You don't need any special diets, you just need a good diet. And there's lots of theories about the benefits of yams and avocados and pineapples, and there's hardly a week goes by without some new fad coming out, and everybody jumps on the bandwagon saying, "Oh, I must not drink coffee. I must eat loads of pineapple or avocado or whatever it is. I think these sort of things are a reflection of a good diet. If you include lots of fruit in your diet, the chances are that that you're eating well. There are things that you shouldn't eat. You shouldn't eat too much fat. Anything that's very close to the checkout desk at the supermarket tends not to be good for you. So by all means eat chocolate, but just not too much chocolate. We all like to go to the local burger bar, but not every day, probably once as a special treat. There are some things that are definitely really bad for you. And I saw a patient yesterday who was obsessed by her weight and her diet, but she smoked 20 cigarettes a day. Now, there is absolutely unequivocal evidence that if you smoke, that's bad for your eggs, it's bad for your sperm, it's bad for fertility, and it's bad for babies. So if there's one thing you take away from this half an hour is, if you smoke, stop smoking, because that is one of the biggest detriments to fertility.
Good, yep. So should we talk a bit about egg quality and sperm quality? So we had a few questions relating to this. So yeah, we've talked about generally keeping your lifestyle as clean and healthy as possible, because all of these things are very important for both egg and sperm quality. A tricky question about whether cancer could affect sperm. So we know it says not treatment of cancer, but cancer itself. We certainly know that some cancer treatments can affect sperm quality, numbers and fertility substantially. It's difficult to answer directly, can cancer affect sperm? Any illness can affect sperm quality, so without knowing more details.
Yeah. Anything that can be life-threatening, such as a malignant disease, will affect your fertility one way and another. And often I will say to patients that if you have influenza or a nasty disease, this will be reflected in your sperm production, and it's as if your body goes into lockdown mode and has to protect itself, so it reduces the functions of less vital parts of your body. So if you're fighting a nasty disease, then probably your sperm count will go down. So I would just qualify what Ali said, was that a malignancy per se will almost inevitably affect your sperm count, but therapy itself can affect it depending on what therapeutic agents you need. But once that's been cured or reversed, or any illness reversed, then there's no reason why your sperm count should come back to somewhere normal, provided your testicular function hasn't been destroyed by the treatment you've had to save your life.
Good. So types of treatment. So we'll just move on to some of the different treatments that we offer. Somebody here, Tash, asking about mild IVF. I'm thinking about whether she should go for IUI before IVF. So it's not a straightforward one. It depends very much on all the situation, circumstances, medical history, all of those things.
Yeah.
But in a nutshell.
Your doctor or fertility nurse will advise you on what's the best treatment for you to give you the best chance of success. It might be intrauterine insemination, it might be IVF, it might be ICSI. I have my doubts about mild IVF, and as a practicing gynecologist, I wouldn't advocate a mild laparoscopy or a mild removal of your appendix. There's no such thing. We always try and do the least we need to do to effectively treat the patient. So IVF itself is not over the top. What we do is to try and use the lowest doses, the least intervention to create the maximum effect. So mild IVF is what we all do, but you just have to be careful when you see adverts for these sort of treatments, because although they imply that somehow they're better, they rarely are. So you need to trust in your clinician, the doctor who's looking after you or the nurse who's looking after you, to give you the best treatment, the most valuable treatment to give you the best outcome. And this is where it's essential that you develop a trust of the clinic that you go to.
Yeah, perfect.
Do you want me to read one for you?
Well,
There's a oh, go on, carry on.
I'm fine. I know where I'm up to. So this was from Amber, asking about the success rates between IVF and ICSI. So she's an NHS patient and wondering whether she could choose between the two treatments. Well, ICSI and IVF are quite different in terms of the way we add the sperm in the lab to the eggs. So with IVF, we prepare the sperm and mix the eggs and sperm together, so there's plenty of sperm there, and the sperm will find the one that fertilises the egg, will bind to the egg and fertilise. We'll check the following day. With ICSI, we will manually inject the sperm, one sperm, into each mature egg. And generally, we will use ICSI, intracytoplasmic sperm injection, for cases where the sperm numbers or the sperm quality are insufficient for IVF. So IVF being a longer established, less interventional procedure, but both are highly successful. So I think the point here would be that we will recommend the treatment that is indicated. So unless we need to do ICSI, then we wouldn't recommend ICSI. But when we do recommend ICSI, we're very confident in the technology. It's very well established, safe and effective.
I'll read the next question because this is a question where Dr. Campbell is a world expert. I read about the new Care Maps algorithm. Can you explain it a bit more, and how is it better, and does it cost more?
So yes, we have recently launched our latest iteration of Care Maps. So Care Maps is something that we've developed. It's exclusive to Care. It's taken us the best part of a decade to get to the point we're at. It's continuously improved. It's based on thousands and thousands of embryos, the data from those, and around a few thousand babies as well. So it's very well established, very successful, and we are very proud that we've just launched the latest version, which is version 6. Yes, it's better than version 5, which was better than version 4. It's continuously improved. And basically what it does is it helps us choose the best embryo first time. So we're analysing each embryo with time lapse, and we're collecting all this information about the time that the embryo develops from 2 cells to 4 cells to 8 cells, etc. And based on those timings, we apply a very sophisticated model algorithm, which will tell us which is the best one. And it actually will give us a score for each of them. We've got scores from 1 to 10. And then we will choose the best embryo and improve the chances of success. So we're selecting the best one first time. It gives us lots of information on all of the embryos. We can cryopreserve, we freeze ones that we're not transferring if they meet the criteria. It doesn't cost more than previous Care Maps. It's the same price, so that's good news too.
And before I joined Care, I've worked in many clinics all over the world, and I have to say Care Maps is very impressive. It's a fantastic bit of kit, and it's well worth asking about if and when you come to Care Fertility. Next question, how do I apply for NHS funding with Care? Well, that's a complicated one. I'll try and be as precise as possible, but the clinical commissioning groups are the NHS funding groups that provide the funding for NHS treatment. And generally speaking, if you're under 42, if your body mass is under 25, and if there's nobody on the planet that calls you mummy or daddy, you will qualify for NHS treatment. But it might not be at the clinic you necessarily want to be treated at. Most of the time it is, and you will be pointed in the direction of the clinic where the CCG has funded. However, what you also have to remember is that the funding is yours. It's not the hospital's, and it's a national health service. It's not a local health service. So in reality, you have the right to take your funding wherever you want to go. It might be difficult, but if you have a particular reason why you want to be seen at a particular clinic, then just speak to your local clinical commissioning group and they may be able to help you. It may not be possible, but you have to remember you have a say in where you have your treatment in the National Health Service. Right. Some quick fire questions.
Right, they're mostly clinical. We've got a 5 centimetre endometrioma. So why does treatment need to be delayed?
If you have a 5 centimetres is the cut-off, generally speaking. 5 or over, it needs to be treated because we don't want it to get in the way of the treatment and reduce your chances. If it's less than that in diameter, it's less likely to cause a problem. Over that, I would say you certainly need to take advice as to whether you should have it removed. Over 5 centimetres, I would be erring on the side of getting it removed before your IVF to give you a better chance.
Yeah. Short protocol or long protocol?
Short.
How long does it take to design a protocol?
It depends on the patient. Very, very quickly. We just need some basic information. We need your ovarian reserve, your scan, your past performance, your age, your body mass index, and we can put a protocol together once we have all that information available to us, which should be available fairly rapidly.
Yeah. Is it okay to take antihistamines during treatment?
It's best to avoid as much medication as possible. Always ask for advice before you embark on your treatment as to if you're taking any medication. Antihistamines are okay. So generally, lowest dose possible though.
Yeah. Why is fertility medication expensive?
That's a bit like saying why are BMWs expensive? Why are Prada handbags expensive? Why is the NHS so expensive? Do you realise in the NHS, although we get it free at the point of contact, it costs £100 for a hospital to see one patient in a clinic. It costs £20 a minute to run a theatre. It costs the NHS £5,000 to do a laparoscopy, £10,000 to do a hysterectomy. So IVF, relatively speaking, is cheap, but unfortunately, it's not available to many of us on the National Health Service, and that's why the perception is it is expensive. Hormones for IVF are no more expensive than many other drugs but unfortunately, if you're self-funding, you need to pay the price, which and like many medications in the NHS, they are more expensive than we'd like them to be.
There's a question about home pregnancy testing. So do we do a beta HCG test in the clinics, or do we accept a home pregnancy test for our patients?
Oh, yeah. If you have a pregnancy test at home and it's positive, if it's a good reputable urinary pregnancy test that you bought from a reputable chemist and not off, some dodgy internet site, then that's fine. We'll accept that. Sure. Yeah.
Yeah. Good. We've got a bit of time, so should we talk about success rates? It's a difficult one, really. We've discussed it before, and it's very hard with limited information to put a value on each patient's scenario. Saying that, I think our website's particularly brilliant. We show our results in a very transparent way. There's also the HFEA website people can look at, where it's stratified by age. Female age being the most significant factor when we talk about success rates. And furthermore, I'd say at your consultation, or if you just want to contact the clinic, speak to an embryologist, a nurse, a doctor, we'd talk you through your own chances of success, because I understand you need to know, you need to set your expectations and make some decisions.
Generally speaking, it's not where you go for your IVF. It's who you are that counts, and that's why you as an individual should have an individualised treatment plan with an individualised outcome prospect. Because for an IVF clinic or a fertility clinic, say your chance of success of 50%. What does that mean? Or our over 40s pregnancy rate is 20%. That's too general. You need to know, what are my chances of success? What are my chances of walking out with a baby? And then you are then free to decide whether you want to go ahead with the treatment or whether not. Some people would say, well, your chance of success is 20%. Well, that might be acceptable to some people. To other people, they may think, well, I don't want to, I don't want to go into a treatment where the chance of failing are 80%. But you are an individual, and therefore you should be treated like one and given your likely prognosis, your chance of success, and then we can make the decision together as to whether we go ahead.
Yeah, and I think you should choose a clinic that has a broad range of treatments, because we like to tailor and fine-tune treatments accordingly. There's a question here about PGTA, which is pre-implantation genetic testing for aneuploidy, and this is something that we do offer across the clinics. It's not for everybody, but it's a very useful tool if we know there's a high risk of aneuploidy in embryos. So this is when the copy number of chromosomes is not correct. And if that is the case, which unfortunately with an increasing maternal age, female age, the chance of aneuploidies does increase substantially. So if that is the case, then the chance of a pregnancy is lower, unless we use PGTA to select the embryos that have the right copy number of chromosomes, and they're called euploid. So hope that's not too complicated, but the point here is that if PGTA is indicated, if it will help you, then we will talk to you about that, and that will hopefully then help us choose the best embryo that's euploid. It reduces the chance of failed implantation, it reduces the chance of miscarriage, and we get a faster time to a success for you.
What are the options for same-sex couples? Well, a significant proportion of our patients are same-sex couples, and I'm always surprised at the breadth of knowledge that same-sex couples have, from very little to quite a lot. But for same-sex couples, I sometimes think it can be particularly difficult when you're embarking on your fertility journey. So it's essential that you get the right information as soon as you possibly can. So to spend an hour or so in the company of a fertility doctor or a fertility nurse that specialises in same-sex couples, you can get an awful lot of valid information that helps you to prepare for that chapter in your life where you're trying to create a family. So in answer to your question, there is a lot of information available for same-sex couples, and just get it as early as you can before you start, so that you know exactly what sort of path you want to take to enable you to have your family.
And should we talk a little bit about the support that's available for patients, because of course this is very important, and I think we do particularly well at this actually. So we have independent counsellors available at all of our clinics. We have on-call support from our nurses, so emergency on-call out of hours as well, and we offer peer-to-peer support. So we have online support meetings, and we used to do walks, communal walks and things like that. They'll come back, and we have a buddy system, which is really nice, I think. So it matches you. It's a bit like dating, I guess, but it matches you with another patient who's at a similar point in their fertility treatment journey. So just to provide that day-to-day support and advice, which is quite nice. So lots of different things that we offer, that we give you some support, additional support.
It's a traumatic journey, so we recognise that at Care, and we want to give you the time. So if you have a problem or you have a question and you might think it's silly, believe you me, it will not be silly to us, because we've heard it all and it might be really important to you. So pick up the phone to your local clinic. There are plenty of opportunities to ask those questions, and if it just helps to improve your well-being, reduce your stress, then that's a success. So never feel as though you're on your own, because it can be a pretty harrowing time for your for you when you go through all this. Infertility itself can be stressful, and adding treatment on the top, we recognise, can be an additional stress, and we need to help you to keep yourself as informed and as calm as possible. And I think Ali's point that she made early on is a very valid one, that we've got 20-25 clinics throughout the country, and in each clinic we have specific specialists in particular areas of fertility, and we talk to each other all the time about different patients. So you're not just getting the advice from one clinic, you're getting the advice from a whole breadth of knowledge throughout all the care group throughout the UK.
We had a question relating to someone who'd had treatment before, which, unfortunately, IVF succeeds or fails as often as it succeeds, pretty much. So patients often come back for repeat treatment cycles. So the question is, what would we do differently on a second treatment cycle compared with the first treatment cycle? And while we have a vast toolkit of treatments, we review very seriously the clinical notes, the embryology records, the patient situation, if it's changed or not since the first treatment cycle that might have failed. And then we will adapt. We may introduce something additional, we may advise, we may change the drug regimen, we may do some different technologies in the lab, but of course, fully informed, we'll discuss the options with you. But we have a process to review in great detail what's gone before. Even if you've had a treatment in a different clinic, then we want to see those notes, we want to hear about it, and we want to see how we can evolve and improve.
We would have the benefit of your previous cycle of treatment so that we could work on that and modify what's been before to improve your chance and give you the best chance of success. There's a question here, how long after the birth of your baby could you try for IVF again? Well, when you finish breastfeeding, obviously you can't get pregnant when you're breastfeeding, so when you feel ready to have another go to add to your family, then that's fine. But really, you need to give as much time as you need to nurture and wean your first baby. And it might, if you're breastfeeding, well, who knows? If you're not breastfeeding, well, whenever your periods revert to normal and you feel you're in a position to extend your family, then come back and see us and we can give you the necessary advice.
Just got a quick question relating to your breastfeeding. Made me remember this question we had here about do you have any expertise in induced lactation for IVF surrogacy patients? I didn't know that was a thing, and we haven't mentioned surrogacy, which is very important.
Yes, we do. A lot of patients who have one reason or why they can't, or there's a technical reason why they have an inability to breastfeed. We do have counsellors, and there are techniques that you can try, which will enable you to breastfeed babies that you may not have given birth to yourself. Don't ever dismiss that likelihood. If you want to breastfeed your baby, then come and see us. We'll give you the necessary advice and point you in the direction that will give you the best chance to breastfeed. I've actually seen patients who have had surrogate pregnancies who've successfully breastfed their own baby once they've had them back into their family.
That's nice.
It's lovely.
So I think that's a nice point to end upon. We've had so many questions, so we're going to get to them. We're going to be busy this afternoon looking through them and try and get back to everybody individually. Remember, there's loads of information on our website, so if you want to go and have a look there, we're here if you need us. We've got the people manning the phones, and it's been a pleasure.
Yeah, and thanks for listening, and I'll fancy some toast.
Shall we?
Bye-bye. We'll see you again soon.